Welcome to Module 7 of Day 1 in the TCCC-Plus course. This lesson covers recognising a compromised airway, opening and protecting it with positioning and manoeuvres, and the nasopharyngeal airway. A compromised airway is a quiet killer, and the second most common killer in combat after bleeding. A casualty cannot shout that they cannot breathe. Instead, they go quiet and then they are gone. However, some may also make some kind of sound demonstrating a failing airway, like snoring, gurgling, or stridor, a kind of whistling noise when breathing. Most of the time, simple positioning is the fix, avoiding complicated devices. We should, however, keep the frequency of airway obstruction in proportion. On the battlefield, airway obstruction may be second, but is still an uncommon cause of death, seen almost only when there is direct trauma to the face or neck. If the casualty is awake and talking in a normal voice, this usually means the airway is open right now, but right now may not last. Snoring or gurgling, choking, a hoarse or absent voice, a falling level of consciousness, facial trauma, blood or debris in the mouth, any of these can signal a threatened airway. What blocks an airway is usually mundane: the tongue, broken teeth or dentures, blood, vomit, or a wad of chew. The first and best move for protecting the airway costs nothing. Sit them up if they tolerate it, or let them choose their preferred position, or at the very least do not force them flat, which can make the airway worse. Sitting the casualty up, or the recovery position if they are unconscious but breathing, does the work. A manual jaw thrust, like you may have learned before, is only a fallback if positioning will not open the airway. The recovery position lets the tongue and fluids fall clear, and the tactical airway flip does the same under fire. A casualty with a smashed face will often protect their own airway better than you can by leaning forward and letting blood drain out, so let them. If there is a lot of debris in the mouth, clear what you can see, but never sweep a finger blindly through the mouth. You can trigger vomiting, push debris further down, or get bitten. These illustrations show some simple airway measures. Again, positioning does most of the work. Sit the casualty up and let them lean forward so blood and vomit drain out, not down. If they are unconscious, the recovery position does the same job. Positioning should be your first move. A jaw thrust is just a fallback. The NPA is mentioned here, but is usually most useful in intoxication-related decreased consciousness and not taught in the skills labs.
To place the casualty in the recovery position, take the casualty's arm and bend it at the elbow, placing the hand underneath and behind the head. Take the other arm and lay it flat across the casualty's chest. Position yourself on the side of the casualty, bending their leg at the knee across their body, grabbing the patient's shoulders and hip and rotating them onto their side, ensuring that the bent knee is on top of the casualty. Place all unconscious casualties into the recovery position unless they have suspected head or neck trauma.
This video shows the use of the recovery position. Again, the nasopharyngeal airway, or NPA, is not commonly necessary or useful in combat and won't be taught in the in-person classes. It is nice to know about though. The NPA is a simple, well-tolerated adjunct, but it is not a definitive airway. To use it, lubricate the tube with a water-soluble lubricant and insert it gently into the nose, straight back, not upwards. Do not force it into a bloody, smashed face, and avoid it with a suspected skull base fracture, and stop if you meet resistance. At this level, airway care is recognition of a threatened airway and correct positioning. In some cases, this may also include placement of an NPA. Supraglottic airways, surgical airways, intubation, and sedation are above this course and are covered elsewhere. There is a hard lesson behind that line. When advanced airways are placed at the point of wounding, survival is poor because a trauma casualty who will tolerate one without sedation is already almost gone. Airways also worsen over time as swelling, secretions, and falling consciousness build, so airway compromise can be found by reassessing regularly. So let's see how airway is handled in the different phases. During care under fire, airway management waits for tactical field care, with the one exception of a tactical airway flip. During tactical field care, the main intervention is positioning, sitting or recovery position, and reassessment. Evacuation care involves keep the positioning, keep reassessing. Common errors include forcing a casualty flat, blind finger sweeps, using advanced airways without necessary experience and expertise, and treating the MPA as fit and forget instead of reassessing. Let's recap. Recognize the quiet signs early. Positioning first. Sit up and lean forward. Recovery position if unconscious. A manual jaw thrust only if positioning fails. The NPA is an adjunct, not definitive. Mind the contraindications and reassess. Thanks for watching our TCCC-Plus for non-medics Day 1 Module 7 about airway. Next up is Module 8, Hypothermia.